અવાજ સંભળાય છે?
Yes, sir.
Good
Hello,
evening.
Miss. Hello, Angelica, ma'am.
Hello.
બસ આપણે તો બોલવા નથી એટલે વાંધો નહીં.
Viewer registrations કેટલા છે?
એ તો આ તો ડાયરેક્ટ એમાં જ આપણને જોવા ના મળે.
હા.
ડાયરેક્ટ ડીઆઈપી માં જ થાય એટલે હવે કેટલું ખબર નહીં હોય એટલે અત્યારે એટલે જ કીધું ઘણા સીધા અત્યારે જ જોઈન થાય ને આમાં તો.
હા. હવે એમાં ક્વેશ્ચન આન્સર સેશન કઈ રીતે લેવાના? ચેટ બોક્સ માં તો એ લોકો ડીઆઈએપી વાળા જ આપણને કહેશે ને, ક્વેશ્ચન ફોરવર્ડ કરશે.
આપણે પૂછી લઈએ.
કારણ કે આમાં તો આપણે ઓન્લી ધીસ ઇઝ પેનલ લિંક, તો વ્યુઅર્સ ની લિંક અલગ છે, તો પછી એ લોકોને ક્વેશ્ચન્સ એમાં આવશે એટલે she has to forward, Akshita has to forward the questions in the our chat box. તો એ જેમ જેમ આવે એટલે આપણે લઈ લેવાના પછી છેલ્લે if there are any questions.
એ છે શ્વેતા છે હોસ્ટમાં.
કોણ છે?
શ્વેતા.
શ્વેતા ઓકે. અને આપણે સ્ટાર્ટ તમે કરશો વેલકમ ઉન્મેશભાઈ કે હું સ્ટાર્ટ કરું?
વાંધો નહીં.
એટલે હું સ્ટાર્ટ કરીને તમને ઇન્વાઇટ કરીશ ટુ સે ધ વેલકમ એડ્રેસ, પછી ઇન્ટ્રોડક્શન ઓફ ટોપિક એન્ડ ઇન્ટ્રોડક્શન ઓફ સ્પીકર, બસ એકદમ શોર્ટમાં. અને પછી હેન્ડ ઓવર ટુ ડોક્ટર સાજન. અને મિતુલભાઈ તમે વોટ ઓફ થેન્ક્સ? કશું નહીં. ઓકે ફાઇન. વોટ ઓફ થેન્ક્સ શું? જસ્ટ થેન્ક્સ ટુ ધીસ બોલી જઈશ હું છેલ્લે.
હું વાયરલ માં સફર કરી રહ્યો છું ત્યારે.
હા અચ્છા,
વાયરલ થઈ ગયું છે. હેલો ડોક્ટર સજન, ગુડ ઇવનિંગ.
ગુડ ઇવનિંગ.
You're muted. You kept yourself muted.
Yeah.
And you need to rename yourself.
Sir, I'm muted.
No.
Not
anymore, not anymore.
okay. Now okay.
You need to rename yourself, doctor. It's just saying DR, doctor. एक nice smiley pose, Unmesh sir.
हाँ.
Sajan, Dr. Sajan.
Yes, sir. I am giving changing my name. It's a rename. Now it's visible, sir. I have changed.
Yes, it is visible. Now one nice smiley pose photograph. Okay, thank you so much.
Thank you, sir. Thank you.
આપણે 9:10 કે એવું ચાલુ કરી દઈશું. 9.
Okay, sir.
5 minutes બાકી છે.
હા.
Sir, you want to share your slides once just to confirm?
Yes, ma'am. Yes, ma'am. Visible?
Yes. Done.
Ma'am, the slide is not moving here.
You have to do slideshow, sir.
Oh, yes, sir. Yes, sir. Yes, ma'am.
Yes, now it is
Okay, I guess we can have a 5 minutes refreshment time.
Yes,
We'll
ma'am.
be back by 9
Yes,
o'clock.
sir.
Okay then.
Okay, okay.
Yeah.
उनमें सर आप बीजेएमसी में थे क्या पहले?
नहीं, मैंने एलजी।
अच्छा, एलजी से किया सर।
आपने कौन से ईयर में किया?
मेरा एमबीबीएस है सर, बीजे से 2001 पेज का।
2001 ना तो बरोबर है। हमारा एमडी मैंने 2004 एलजी में 2004 में था।
ओके सर।
I have done from PG, post graduation,
ओके मैम।
2001 to 2004.
Okay,
MD.
then Momin madam was there, HOD.
Yeah, we were under AHA, Anjana Shah unit, HOD unit.
Okay.
So maybe we would have met. ध्यान नहीं है। आपने पीडियाट्रिक वहां से किया है कि?
मैंने मैम यूसीएमएस दिल्ली से।
अच्छा, तो फिर नहीं मिलना होगा। I've done my PG from there. UG
BJMC.
Abida Momin, Anjana Shah, Pratima Shah, they were all there in the pediatric department.
My attendees કેટલા જોઈન થયા છે એ આપણને નહીં ખબર પડે।
श्वेता ने खबर હોય DIP वाला अभी है ना डॉक्टर साजन, we can stop the screen share.
Okay.
And then when I invite you, then you can start.
Oh, okay.
Shweta, are you there?
Yes, doctor, will start sharp at 9.
Yeah. Any idea about the number of attendees right now?
Not yet, doctor. They are on the viewers link, no? So I can't check them actually.
Okay, so
I'll share the report separately.
Okay, we can't come to know right away now, right?
No, not now.
Fine, no issue. And if there are any question and answers, what you can
I'll
do
post
is
that in the chat box.
Yeah, just forward them in the chat box.
Yes.
Nine o'clock.
एक 2 मिनट खाली मितुल भाई चाहिए।
अच्छा।
I'm online only. I was just trying to check from a viewer's link whether it's functioning or not.
Okay, shall I start?
9 o'clock.
Okay. Recording in progress. Good evening, everyone, to all the viewers present here and my esteemed panelists. I welcome you all on behalf of Academy of Pediatrics Ahmedabad for today's webinar. Before we start, I'd like to invite the President of AOP Ahmedabad, Dr. Unmesh Upadhyay, to give his welcome note.
Good evening, everyone. On behalf of AOP Ahmedabad, I welcome today's speaker, Dr. Sajan Agrawal sir, who is a pediatric gastroenterologist, and I welcome also all AOP members in this webinar. Now I hand it over to Dr. Andika to moderate the session further.
Thank you, Dr. Unmesh. So today we are here on this live platform to discuss an important topic. We all know that day in and out, we are bombarded with so much information about probiotics nowadays. We have so many representatives coming to meet us in our OPDs and advocating one probiotic or the other. So it really creates confusion in our minds at times, like which probiotic to use when. So today's topic is an important one. The title of today's webinar is The Role of Probiotics in Dysbiosis and How to Choose the Ideal Probiotic. So I'm sure that today we are going to have a really enlightening session on this topic. For this, we have with us our speaker for today, Dr. Sajan Agarwal. Welcome, sir. He is a consultant pediatric gastroenterologist and hepatologist at Gujarat Gastro Hospital, Surat. He has done his fellowship in pediatric gastroenterology from SGPGI Lucknow, as well as in pediatric hepatology from ILBS New Delhi. He is the EB member of the ESPAGAN 2024-25. He has many papers published in international and national journals, has won the Best Paper Award in oral presentation in Pedicon 2011 at Gurgaon. And Dr. Sajan has special interest in neonatal and pediatric liver diseases, as well as pediatric GI motility disorders. Welcome, sir.
Thank you, ma'am, for the nice introduction, and AOP Ahmedabad to giving me this opportunity for today's talk. Can I share my screen?
Yes, sir.
So today's talk on the role of probiotics in dysbiosis. So how to choose an ideal probiotic. So before going to the probiotic and dysbiosis, we have to understand some definition. Like, what is microbiota? Microbiota is a living microorganism found in the defined environment. Defined environment means the oral microbiota will be different in the from the gastrointestinal microbiota, and gastrointestinal microbiota will be different from the genitourinary microbiota. So different microbiota in the different defined environment. What is microgenome? Microbiome is a collection of genome from all the microorganisms in the environment. So microbiome of a person in a family could be different from other person of the same family. And if there is a balance in the microbiota community and there is a diversity in the microbiota, it is called eubiosis. If there is an imbalance in the microbial species and there is a reduction in the microbial diversity, it is called a dysbiosis. So today's talk on the role of probiotic, it is beneficial in case of dysbiosis. So we will see in the next slide. So how we human gain the gut microbiota during infancy and then in the later period. So in the intrauterine period, we get the microbiota through amniotic fluid, and at the time of birth, we get from the environment, vagina of the mother and the skin. And after that, breast milk, and after the weaning, we get the microbiota from the solid food, and during childhood, the high fiber diet and high carbohydrate. But if there is a change, like if baby is born by the cesarean section, or baby on the formula milk other than breast milk, or baby is received any antibiotic for any problem, or baby on child on the western food, so the microbiota will be changed. This is called dysbiosis. So there is a hypothesis that dysbiosis can lead to various disorders like autoimmune disorder, inflammatory bowel disease, GI disorder. So we are going to search that this probiotics will helpful in such dysbiosis or not. So in last 15 years, there is a lots of research articles on probiotic in children. You can see there is at least 3,000 results is there on PubMed. So we are still in the middle of the hip or hype. So the probiotic is hype by the pharmaceutical company, or it's actually the useful. So we have to see understand the truth. So how to determine the hip or high? So probiotic, in which disease it is useful? It's infectious disease or allergic disorder or functional GI disorder, which strain, single strain, multiple strain, and what dose it is useful. And important thing is credibility of scientific data. So if we are reading any article, we have to say, check the credibility. We have to check the acknowledgement section. We have to check if there is any conflict of interest is there. If this author is funded by the pharmaceutical company. So if they all these parameter is fulfilled, means we can say that this article is not useful. This article is not genuine. So it's very important to check the credibility of the data, because lots of data is basically driven by the pharmaceutical company. Angle of analysis means that depend on the demographic country, means the any probiotic study which is happened in the European country, the demographic condition is different in the European countries other than American country and Asian countries. So one study which is probiotic, which is showing the probiotic is useful in one population, may be useful in Asian population or American population. So this data should be extrapolated in the other population also. And the other thing is a personal observation and the bias. So we all know that change in the gut microbiota lead to dysbiosis, and which can lead to infection, genetic disorder, and allergic disorder, autoimmune disorder, functional disorder. But I have to say that other than dysbiosis, there are many other risk factors of disorder. So dysbiosis is one factor. So we are searching the role of probiotic. So probiotic can be used as a therapeutic agent or can be used as a prophylactic agent to prevent this disorder. As well as we have to know that probiotic which we are using is efficacious and a good safety profile. So now we will take the examples. Necrotizing enterocolitis. We know that the necrotizing enterocolitis is a catastrophic condition associated with the premature baby because of the immature intestinal barrier, immature gut immunity, altered gut microbiota, translocation of the bacteria. Because the premature baby contains a different microbiota than the term baby. The high enterobacteriaceae and the less lactobacilli and the less bifidobacteria in the gut of the preterm baby, which lead to late onset sepsis and lead to necrotizing enterocolitis, and 50% of these cases landed to the surgery, and there is a high risk of mortality. So can probiotic help in the prevention of necrotizing enterocolitis or progression of enterocolitis? So there is a meta-analysis including the 51 RCT included 11,231 preterm infants. So few studies found that it may help in the prevention of the necrotizing enterocolitis from grade 1 to grade 2 and grade 3 late onset sepsis. But most of the other studies found that they are not useful. So there is a paucity of eligible study till now. What Ispagan 2022 says, Ispagan is European Society of Pediatric Gastroenterology, Hepatology and Nutrition. They say that probiotic is can be useful with the low certainty evidence if there is a microbiological test to detect fungemia, because in premature baby are immunocompromised. So probiotics should not contain any fungal because it can lead to fungal sepsis. None of the probiotics should produce D-lactate because it can cause D-lactic acidosis. Should not contain any antibiotic resistant capability. And important thing is when we are using probiotic in the preterm baby to prevent the progression of necrotizing enterocolitis, informed consent should be taken from the parents. So Spagan recommended that lactorhamnosus GG in the dose of 10 to the power 10 colony forming unit or combination of bifidobacterium and streptococcus thermophilus can be used to prevent the progression of NEC from stage 1 to stage 2 and stage 3 with the low certainty of evidence. But there is a no optimal duration is known. We can use up to 4 to 6 weeks or until discharge, which is acceptable. Ispagan says that Lactobacillus reuteri and combination of bifidum and Lactobacillus acidophilus should not be used in NEC, and they had given the against recommendation for the Bifidobacterium brevis or Saccharomyces boulardii, because Saccharomyces boulardii is a fungus yeast, so it is a contraindicated in a premature baby, and other probiotic produce the D-lactate. The another meta-analysis found that the probiotic prevent the progression of NEC in 3.5% of the premature baby, and it prevent the gut associated sepsis in 15.6% cases, which is very much significant, and prevent the mortality in 5.2% cases. In best outcome was in premature baby less than 32 weeks and or less than 1.5 kilo baby. So what American Gastroenterology Association said that in preterm baby, low birth weight infant, they suggest that combination of lactobacillus species and bifidobacterium is highly recommended to prevent the progression of necrotizing enterocolitis. So ISPAGAN, it's our Indian Society of Pediatric Gastroenterology and Hepatology recommendation in 2022. They said we can use the combination of lactobacillus species and bifidobacterium species for 4 to 6 weeks in premature baby to prevent the NAC. If these combinations are not available, then we can use lactobacillus rhamnosus GG in the dose of 10 to the power 10 for 4 to 6 weeks or until discharge. It is helpful in reducing the risk of necrotizing enterocolitis stage 2 with reduction of late onset sepsis, mortality, and reduce the time of full feed. So there was moderate to high quality of evidence in the preterm baby. But still there is a gap in the research in preterm because these studies are heterogeneous. What dose should be used, which time probiotics should be introduced in the preterm baby, and for what duration it should be used. And there is a lack of data on the premature baby less than 28 weeks or less than 1 kilo baby, and effect of the enteral feeding of the baby, either baby on the mother milk or the formula milk, the effect of the probiotic on such baby, that is still missing. So we need a more study, especially the Indian study, to say that probiotic is helpful or in the prevention of NAC. Now the second example is acute infectious diarrhea. So world is divided into two parts. North America and Western Europe said that probiotic is not useful in the acute diarrhea. But the Eastern Europe and some Asian countries said that probiotic is useful in the acute diarrhea. So how to measure the efficacy of probiotic? So probiotic, if it decreases the duration of diarrhea, it decreases the volume of stools, or it decreases the hospitalization durations, means it's efficacious. So, and the research purpose, we can use modified basic acid scale, which is using since Vibrio cholera time. So what European guidelines say, there is a weak recommendation of Lactobacillus GG or Saccharomyces boulardii and Lactobacillus reuteri in case of acute diarrhea. And Bacillus clausi is not recommended by the European guideline. And combination of Lactobacillus helveticus and Lactobacillus rhamnosus and other combination Lactobacillus rhamnosus and Lactobacillus reuteri, European guidelines say they are against recommendation. So the dose should be, we should remember that 10 to the Lactobacillus rhamnosus GG should be used more than 10 to the power 10 colony forming unit per day for 5 to 7 days in acute diarrhea. Saccharomyces boulardii 250 to 750 milligram per day for 5 to 7 days, and reuteri can use 10 to the power 8 to 10 to the power 9 colony forming unit for 5 days. What American Gastroenterology Association said, there is a marginal decrease of diarrhea by the various probiotics. The overall, if we see the effect, decrease in the duration of diarrhea is 22 hours. So they were given the verdict that probiotic is not useful in the case of acute infectious gastroenteritis. But our Indian guidelines recommended we can conditionally use Lactobacillus rhamnosus or Saccharomyces boulardii in acute infectious diarrhea as a adjuvant therapy along with the WHO ORS and zinc. There should be marginal cost benefit advantage should be given, and there is no recommendation to use Lactobacillus reuteri or Lactobacillus acidophilus, and there is no recommendation to use any combination of probiotic. So Indian guidelines says in acute infectious diarrhea we can use Lactobacillus rhamnosus GG, Saccharomyces boulardii. There is no role of combination of probiotics. So now we will take different study. This is the American study on Lactobacillus GG randomized control trial. They found that there was no benefit of these probiotics in acute infectious diarrhea. Other study from the North America, the combination of Lactobacillus helveticus and Lactobacillus rhamnosus, this study also found that there is no benefit. So what is the criticism of both the trial? The opponent said that North America does not represent the world. So maybe this probiotic may not be helpful in North American population, but European population and the Asian population. And in these trials, majority of the children were immunized for the rotavirus, and probiotic were given after 48 hours of the diarrhea. So, so as per the European perspective, this meta-analysis on the lactobacillus GG, they found that it is helpful in the reduction in the duration of diarrhea by 0.85 days, approximately 1 day, and daily dose of more than 10 to the power is better than less than 10 to the power 10, and there was reduction in the hospitalization by 1 day. So they found that this is useful not only in the reduction in the duration of diarrhea, also in the reduction in the hospitalization. The other in Asian perspective included the 4 Indian randomized control trial. They found that lactobacillus GG decreased the duration of diarrhea by 1 day, and when higher dose was used, and most effective when introduced less than 72 hours of diarrhea, and better in the rotavirus diarrhea with high dose. That's meta-analysis on Saccharomyces boulardii. Saccharomyces boulardii is also found to be reduce the duration by 1 day, reduce the hospitalization by approximately 1 day. And the study on the Bacillus clausii, they found that there was reduction of duration of diarrhea by 9 hours and reduction of duration of hospitalization by approximately 1 day. But the cost of the treatment was 472 rupees compared to ORS therapy alone. So cost benefit should be given. So the therapy should be individualized. There was no Indian study on the Lactobacillus reuteri in acute infectious diarrhea. So summarize the Indian studies. So we found that Lactobacillus rhamnosus GG, Saccharomyces boulardii, and Bacillus clausii could be beneficial in case of acute infectious diarrhea with moderate quality of low to moderate quality of evidence, and there is no role of Lactobacillus reuteri because there is no study on Indian population. But when we pulled the non-Indian and Indian data, they found that there is no impact, a poor impact of these probiotics on the acute infectious diarrhea, and they found that there is no role of combination of probiotic and acute infectious diarrhea, but still there is a lack of the data which can clarify that the probiotic is useful or not useful in acute infectious diarrhea. The role of probiotic in other diarrhea like antibiotic associated diarrhea, Clostridium difficile diarrhea, nosocomial diarrhea, and inflammatory bowel disease, we will take one by one. So antibiotic associated diarrhea, we know that these antibiotic associated diarrhea mostly commonly associated with the antibiotic like amoxicillin, ampicillin, cephalosporin, fluoroquinolones, and broad spectrum penicillin. But the difficult part is the diagnosis of antibiotic associated diarrhea, because it can occur within few hours or up of starting antibiotic or up to several months of discontinuation of antibiotic, and it is usually mild in most cases. So what European guidelines say, they said that if there is an associate factor like class of antibiotic which are responsible for antibiotic associated diarrhea, and the duration of antibiotic it is more than 10 days, or old age patient, there is a comorbidity and there is a history of previous antibiotic associated diarrhea, so high doses of Saccharomyces boulardii and Lactobacillus rhamnosus GG can be used to prevent the antibiotic associated diarrhea. What Indian guidelines say, it does not recommend the routine use of probiotics in immunocompetent children, but it may be prescribed in special situations where risk of antibiotic associated diarrhea is very high and very high morbidity and mortality, and does not recommend any probiotic to prevent the Clostridium difficile antibiotic associated diarrhea. So they found that if there is a moderate risk, means antibiotic is using responsible antibiotic using for more than 10 days, patient is sick, immunocompromised, then we can use Lactobacillus rhamnosus GG or Saccharomyces boulardii. American guidelines said that single strain of probiotic or 2 strain of probiotic, 3 strain combination of probiotic, 4 strain probiotic can be used to prevent the Clostridium difficile diarrhea, because Clostridium difficile infection is more common in the Western country compared to Asian country. So they have recommended antibiotics should be probiotics should be used along with the antibiotic if there is a high risk factor. But when to give, how to give, who to give, and how long should it probiotics should be given, it's still recommendation is not there. Now the role of probiotic in other diarrhea, in that there is no role of probiotics in the treatment of diarrhea. It's antibiotic associated diarrhea. There is no role of probiotic in the inflammatory bowel disease like ulcerative colitis or Crohn's disease. There is no role of probiotic in the treatment of persistent diarrhea. There is a role of probiotic in the case of pouchitis. Pouchitis is a pouch formation usually done after rectal surgery in case of inflammatory bowel disease, which is most commonly seen in the adult population, where ileal pouch is formed in place of rectum. So because of the non-specific inflammation, because of the dysbiosis or bacterial overgrowth, there could the patient may present with a bleeding per rectum, where high dose of VSL-3 is recommended. VSL-3 is a combination of three probiotics. One is a lactobacillus, second is a streptococcus, third is a bifidobacterium. But Indian VSL-3 contains very low dose of VSL. So we usually give in the double dose of VSL in the TDS dose. So the European guidelines say for the nosocomial diarrhea prevention, lactoluminescence GG can be used, but the out of 7 trials, 5 trials were funded by the pharmaceutical companies. So authentication is in question. There is no role of Lactobacillus reuteri. Now come to the role of probiotic in the pediatric allergy, food allergy, atopic dermatitis, eczema, allergic rhinitis, and asthma. They found that there is no recommendation of using probiotic during infancy. In functional GI disorder like infantile colic, functional abdominal pain, irritable bowel syndrome, regurgitation, and constipation. In infantile colic, the study on the Lactobacillus reuteri for the treatment of infantile colic, they found if the Lactobacillus reuteri is used for 21 days in a breastfed baby, then European guidelines said it conditionally we can use the Lactobacillus reuteri for 21 days in the dose of 10 to the power 8 in a baby with exclusive breastfeed infant, not on the top feed. So the condition is the colic infant baby, there should be no red alarming sign. If there is a red alarming sign, then we should protein and GERD, and we have to exclude all these conditions. If the colic is not self-remitting and baby on the breastfeed, then we can use Lactobacillus reuteri. There is no role of probiotics in the prevention of colic, regurgitation, and the functional constipation. There is no role of probiotic in the irritable bowel syndrome and functional abdominal pain. So, crux of the presentation is there is a high quality of evidence is there in the for prevention and the preterm baby for the progression of NAC. So, combination of strain should be used in necrotizing enterocolitis after taking the consent of parents, and VSL-3 can be used in the pouchitis. Low quality of evidence is there for using Saccharomyces boulardii and Rhamnosus GG in acute infectious diarrhea. And American and European guidelines also recommend the use of probiotic and antibiotic associated diarrhea, but Indian guidelines does not recommend. Lactobacillus reuteri can be used in infantile colic, but there is no recommendation of probiotic in case of irritable bowel syndrome, food allergy, persistent diarrhea, IBD, or treatment of Clostridium difficile therapy. Thank you.
Thank you very much, Dr. Sajan, for the excellent session. Many things became clear, so we should think before we ink probiotics in our routine OPDs and use them only for selective situations. If there are any questions, we can take them up right now. Any of the panelists, any questions? Anyone can share their experiences also with the use of probiotics.
Dr. Sajan, what is your take on using this L-deutery in this neonatal age group and early infancy during first 3 months for colic, infantile colic basically?
So actually, truly speaking, I have not used the Ruteri in infantile colic, but I saw if the infantile colic is there is with no red alarming features, and the baby is on the breastfeed, then we can use. But we have, if there is a red alarming features, there is a failure to thrive, then we have to rule out first cow's milk protein allergy and GERD. So after exclusion of all these condition, we can reassure the parents that it will subside spontaneously, but if does not respond, then we can use probiotic for 21 days in such baby.
Because many of the times it happens that, sir, mother doesn't turn up, but father, grandmother, grandfather, uncle, auntie, they all turn up with the child. That saying that mother is not unable to sleep and we are also unable to sleep. Do something so that the baby sleeps and we also sleep.
Yes,
That
sir.
is sometimes a challenging task for us.
Yes, sir. Yes, sir.
I have used Rotary in a couple of babies with infantile colic as a last resort after explaining, after counseling. And I don't know if it really works, maybe just a placebo effect. But since it's a long-term therapy of 3 weeks, we are happy because the patient doesn't keep on coming again and again to us.
Yes.
And I think it may offer some benefit.
Yes.
But the babies I had prescribed were mainly formula-fed babies because they have more issues of colic. So I was not aware that you cannot use Rotary in formula-fed babies and only in exclusive breastfed babies. This is something new that I understood from today's session.
Yes. My next question was supposed to be same. Why not to be used in?
Actually, exclusive breastfed babies don't need anything because they don't get colic. Most of the times, we don't see much colic in breastfed babies. It's more so with formula-fed and bottle-fed babies. So what to do for them?
So there are lots of preparation are available, but they are also not recommended. Like lactase drop preparation is available to lactase intolerance is there. If there is a failure to thrive, there is a bloody stool and other symptoms also, then we can use the formula, hydrolyzed formula. We can use the amino acid formula. If baby is irritable, there is no recommendation of PPI trial in less than 1 year of age. So if you are suspecting GERD in such condition, we have to search for to confirm the diagnosis either by upper GI endoscopy, or if there is an extraesophageal symptom, then we have to do for 24-hour pH impedance So after ruling out all this, we can give the probiotics in breastfed baby, but usually we see the infantile colic in the non-breastfed baby. So I think the research is needed for this non-breastfed baby use of Ruteri in the non-breastfed baby.
Okay.
Sir, just one more thing. I just saw a recent paper saying that PPIs should not, just on the last 1 or 2 days back only, I saw this article saying that PPIs should not be given in children. And we have been using PPIs since many times. So what is your take on that? And how long should it be given? Any risk of giving for long term? What is the recommended duration of treatment?
There is a 2 recommendation. If any older children more than 1 year of age present with the typical symptom, retroesternal chest pain, usually 1 year, 2 year child does not say that they have retroesternal pain. More than 5 years old child kid can say that. So if there is a typical symptom, then we can give the trial of PPI in more than 1 year of age for 2 to 4 weeks. If patient respond, then complete duration of therapy is 8 weeks. But if there is a no response to PPI, then we have to work up. In infantile, if infant present with the suspected GERD, like irritability, like failure to thrive, iron deficiency, anemia, then we have to look for the cause. For to confirm the giardiasis, upper GI endoscopy, if there is erosion in the esophagus and biopsy says that there is changes of GERD like basal cell hyperplasia, elongation of rete cell, then it is the histological confirmation of, and sometimes eosinophilic esophagitis can present as a GERD. So biopsy can confirm the eosinophilic esophagitis also. So if there is a upper GI endoscopy is normal, biopsy is normal, then we can go for the 24-hour pH metry.
So we can use PPIs for a maximum of 8 weeks duration.
8 weeks,
those who are confirmed cases of GERD.
Yes, ma'am. Confirmed case means there is a endoscope erosive esophagitis is there, histological finding is there, then or the patient is responding to trial of PPI. If there's a typical symptom and they're improving with 2 week to 4 week of trial, then we can continue the PPI up to 8 weeks.
And what about those infants, the newborn babies, almost 2-3 months age, who come with a lot of reflux and GER, not GERD, but gastroesophageal reflux. So generally, the first line, what is now recommended is PPI only. Earlier, we used to prescribe domperidone drops for temporary relief, but what I know is that the PPIs should be used. So is that recommended really, and what is the dose?
The recent recommendation by Indian Society of Gastroenterology, ISG, they said that PPI should not be used in trial basis in less than 1 year of age.
Okay.
If baby is only GER, then only reassurance. We can't use PPI, we can't use prokinetics. Even prokinetics we can use, can't use.
Okay.
But because of the patient coming to us again and again, we use probiotics, only domperidone. We can't, there are multiple probiotics is available in the market, duosulfuride, metoclopramide. They are with the very much side effect, like extrapyramidal side effects. So we should not be use the other probiotics. Yes.
Yeah. Okay, but no PPIs. So you are saying
No
not
PPI,
prescribe those
yes,
Isomax sachets and all that we normally used to prescribe.
Even in the suspected GRD, we should not use PPI. Then in GER, we should not. If there is we know there is no red alarming features, only baby is spitting out the feed. So it
only
GER,
counseling.
it will improve. Counseling, and it will improve with the time.
Fine.
If we use probiotics and zinc combination, then how many days we shorten the total duration of symptoms? Any study?
And I think, sir, there's a few study only. They found that they can be used, but the recommendation they said that there is a combination should not be used along with the probiotic. Zinc combination should not be used with along with the probiotic. So cost benefit, all we have to see also. If there is a cost duration is probiotic decrease the duration of diarrhea. Probiotic does not decrease the severity, that decrease the duration of the, it decrease only the 20 hours or 15 hours. So, and the cost is 500 rupees, means it's costly, I think. So we should not use the probiotic in infectious diarrhea also.
So practically we should not use probiotics.
Probiotic, yes, American guidelines, they say that it is not useful, but because the demographic, they are different, their nutritional status is different, their immunization is different. So we can't take their meta-analysis to our population. We need more research in role of probiotic in infectious diarrhea in Indian population, because most of the research article on probiotic from the Western country.
Right. Shweta, are there any questions from the attendees? If there are no questions, then we can wind up. Shweta? I guess there's nothing in the chat box. Mitul bhai, should we just wind up? Unmesh bhai?
Certainly, ma'am.
No more questions, right? Okay, then thank you very much, Dr. Sajan, for the nice lecture. And thankful to AOP Ahmedabad and Central IAP and of course DIAP for providing us this platform. Thank you.
Thank you all. Have a great night. Good night.
Thank you, sir.
Good night. Good night.